Your doctor has checked your blood work for years, told you everything looks fine. So why does your belly keep growing, your energy stay wrecked, and your body feel like it's running on fumes? The problem isn't what they found, it's what they never looked for. I'm Dr. Harris, clinical physician with over 15 years of practice. What I'm sharing today doesn't come from a pharmaceutical pamphlet or a committee of advisors with industry ties. It comes from peer-reviewed research that the conventional medical system has every financial incentive to keep out of your 10-minute appointment. Here's what the data shows. 38% of all adults worldwide right now have fat accumulating in their liver without knowing it. 1 in 3 people. No symptoms, no warning from their doctor. Projections published in Clinical and Molecular Hepatology in 2025 put global prevalence past 55% of adults by 2040. Your kidneys tell a similar story. After age 40, your glomerular filtration rate, the measure of how efficiently your kidneys clean your blood, declines naturally every single year. By your late 50s, most people have lost between 20 and 30% of their kidney filtering capacity. Their doctors call the numbers normal. Normal is not optimal. And that gap between normal and optimal is where chronic disease quietly builds. Today I'm going to show you exactly what is happening inside your liver and kidneys right now, why the standard medical approach misses it almost entirely, and what specific beverages, not supplements, not medications, the science with over 150,000 participants studied actually validates for addressing this damage. The evidence is real. The mechanisms are documented. Not one of these things requires a prescription. If you've been looking for this kind of information, evidence-based, no product pitch, subscribe. I publish this because it should be in your doctor's office, and it isn't. Now let's get into what the system doesn't tell you. Your doctor runs what's called a basic metabolic panel. It checks your glucose, your kidney creatinine, your electrolytes. It's the standard checkbox for the annual physical. What it does not check, ALT, AST, and GGT. The 3 liver enzymes that reveal whether your liver is quietly inflamed or accumulating fat. It doesn't include microalbuminuria, the early warning signal of kidney damage that shows up years before your creatinine changes. It doesn't calculate your eGFR at the level of precision that would tell you something meaningful for your age and metabolic state. These are not obscure tests. They are the tests that would actually tell you something is going wrong before it becomes a crisis. Ask yourself, when was the last time your doctor ordered a liver enzyme panel without a specific reason to suspect a problem? For most people in their 40s and 50s, the answer is never. That's not an accident. Standard insurance-covered checkups are built around detecting acute illness, not preventing metabolic decline. The system is reactive by design. The approved treatment pathway for non-alcoholic fatty liver disease, now officially renamed metabolic dysfunction-associated steatotic liver disease or MASLD, focuses on weight loss counseling, vitamin E in selected cases, and pioglitazone for patients with concurrent diabetes. That is the entire menu from the major liver associations. Meanwhile, a meta-analysis pulling data from 147,175 people sat in published literature showing that a specific dietary behavior reduced liver fibrosis risk by 33%. The guidelines don't mention it. The reason is simple. There is no patent on it. There is no revenue model, so it never made it into the recommendations your doctor was trained on. That's not conspiracy. That's how incentive structures work in medicine, and it's the reason you need to understand this yourself. Let's talk about what the research actually shows. The first piece of evidence that changed how I think about liver health came from a 2022 umbrella review and meta-analysis published in Frontiers in Gastroenterology, pulling data from 9 studies covering 147,875 subjects. The finding: regular filtered coffee consumption was associated with a 33% reduction in hepatic fibrosis risk, an odds ratio of 0.67 with a 95% confidence interval of 0.55 to 0.80. Fibrosis is the step between fatty liver and cirrhosis. Stop the fibrosis, you stop the progression. That number is not a marginal effect. It is a clinically meaningful reduction in one of the most common serious liver conditions developing in adults over 45 right now. The methodology matters. This wasn't a survey. It was a synthesis of multiple independent studies reviewed systematically. The limitation to acknowledge is that most of the underlying data is observational, not randomized controlled. But 9 independent study populations pointing in the same direction is not a signal you dismiss. What the guidelines dismiss anyway, because the recommendation would be to drink coffee, and there is no billing code for that. The research went further. A 2022 systematic review and meta-analysis from researchers at Tabriz University looked specifically at liver enzyme levels. When they pooled data on coffee consumption and ALT, alanine aminotransferase, the primary marker of liver cell damage, they found coffee drinkers averaged 12.5 international units per liter lower ALT compared to non-drinkers. For AST, aspartate aminotransferase, the gap was 9.23 units per liter. Those are measurable biochemical differences that any doctor can verify with a blood draw. Now here is where it gets more specific, and this is where most health content gets it wrong. A 2024 review published in Foods through MDPI identified the precise molecular agents driving this effect. It is not just the caffeine, it is the chlorogenic acids, polyphenols that survive the brewing process and act independently on lipid and glucose metabolism. In a prospective cohort within that review, liver fibrosis incidence was 8.8% among coffee consumers versus 16.3% in non-consumers. P-value of 0.038, statistically significant. And here's the critical finding. Decaffeinated coffee showed similar benefits. That tells you the mechanism isn't primarily caffeine stimulation. It's the chlorogenic acids acting on the liver's fat metabolism pathways directly. Filtered drip coffee retains the highest concentration of these compounds. Espresso loses them in high-pressure extraction. Instant coffee has almost none. The type of coffee matters. Nobody tells you that. The kidney evidence is equally solid. A randomized controlled trial published in Frontiers in Nutrition in 2023 tested the effects of green tea at 7.5 grams per day on patients with type 2 diabetes and diabetic nephropathy. 3 groups, 60 days of follow-up. The 7.5 gram group, approximately 3 cups of brewed green tea, showed improved lipid profiles and HbA1c with no adverse renal effects. This was a population with existing kidney damage. If green tea protects kidney function there, what does it do in someone whose kidneys are declining silently from age and metabolic stress alone? A broader systematic review in Frontiers in Physiology mapped the renal protective effects of EGCG, epigallocatechin gallate, the primary bioactive compound in green tea, across multiple kidney disease models. The mechanism runs through 2 master pathways, NRF2-HO1 activation for antioxidant protection and NFKB inhibition for anti-inflammatory defense. No drug approved for chronic kidney disease targets both simultaneously with this safety profile. Green tea does. One more study. An RCT published in Frontiers in Nutrition in August 2023, Fateh and colleagues compared beetroot juice against Mediterranean diet and a combination in patients with diagnosed MASLD using liver ultrasound to measure steatosis. Result: the beetroot juice group showed more significant reduction in hepatic steatosis than the Mediterranean diet group alone. The mechanism runs through dietary nitrates converting to nitric oxide in the gut, vasodilating the liver's circulation and reducing fat accumulation. The betalain pigments, the compounds that make beets red, add a second antioxidant layer directly protecting liver cells. That RCT exists. Your doctor will not mention it at your next checkup. Why does all of this happen? Here's the biology your doctor doesn't have 10 minutes to explain. The first mechanism is what I call silent hepatic lipid overflow. When you have even mild insulin resistance, which affects a substantial portion of adults in their late 40s and 50s, excess free fatty acids from visceral abdominal fat flood into the liver faster than it can process them. Mitochondria inside liver cells get overwhelmed. Oxidative stress builds. Inflammation begins. Fat starts accumulating inside the liver tissue silently over years. Think of your liver like the oil filter in a car engine. Run cheap, contaminated fuel for decades, and the filter clogs. It still functions, but efficiency drops, heat builds, and the damage compounds. The engine doesn't seize suddenly with warning lights. It degrades gradually until the damage is advanced enough to show up on a test. The reason this matters, especially between 45 and 65, insulin sensitivity declines naturally as muscle mass decreases. Skeletal muscle is the primary tissue that clears glucose from the blood after meals. As sarcopenia, the age-related loss of muscle, begins in the 40s, glucose disposal becomes less efficient, insulin rises to compensate, and the liver becomes the metabolic overflow basin. The conventional approach treats this as a future problem, something to monitor until it becomes diabetes, then address with medication. The evidence says the liver is accumulating damage years before that diagnosis, years of opportunity wasted. The second mechanism is TGF-beta-driven fibrogenesis. the machinery that turns a fatty liver into a scarred one. TGF-beta is transforming growth factor beta, a signaling protein that activates stellate cells in the liver to produce collagen. When the liver is chronically inflamed, TGF-beta stays elevated, stellate cells stay activated, and collagen keeps depositing. That process is fibrosis. Enough fibrosis becomes cirrhosis. Caffeine directly inhibits TGF-beta expression and its downstream mediator, CTGF, connective tissue growth factor. Chlorogenic acids work separately to reduce the lipid accumulation that triggers TGF-beta activation in the first place. Two different molecular mechanisms, one beverage, working simultaneously on the fibrosis pathway. The 33% fibrosis reduction has a precise biochemical explanation. It is not coincidence. The analogy that makes this concrete: fibrosis in the liver is like rust forming inside a steel pipe. The pipe still carries water, but the rust narrows the channel, weakens the wall, and makes eventual failure more likely. The caffeine and chlorogenic acids act like a rust inhibitor, not removing existing damage, but actively stopping new corrosion from forming. Every day you don't address the mechanism, more rust accumulates. The third mechanism is NRF2 pathway suppression in the kidneys. NRF2 is the master antioxidant regulator inside your cells. When activated, it switches on dozens of genes that produce protective enzymes: glutathione, heme oxygenase 1, superoxide dismutase. These enzymes neutralize the reactive oxygen species that damage kidney tubular cells and glomerular tissue, your kidney's internal repair system. The problem: as you age, NRF2 activation becomes blunted. Your antioxidant defenses weaken precisely when cumulative oxidative stress is highest. The result is accelerated kidney aging, faster loss of filtration rate, increased vulnerability to medication toxicity, and blood pressure fluctuations. EGCG from green tea physically disrupts the KEAP1 NRF2 complex, the molecular lock that keeps NRF2 inactive, releasing it to enter the cell nucleus and activate those protective genes. It simultaneously inhibits NF-κB, reducing the inflammatory signaling that drives renal fibrosis. Think of your kidney's filtration membrane like the fine mesh in a high-performance water filter. Every day, millions of molecules pass through that mesh. Over decades, oxidative damage weakens the fibers. EGCG is the maintenance compound that preserves mesh integrity, reducing the wear that slowly compromises function. Dialysis happens when the mesh fails completely. The time to protect it is before the creatinine climbs out of range. The fourth mechanism is hepatic nitric oxide deficiency. Your liver's blood flow depends in part on nitric oxide to maintain healthy circulation through the hepatic sinusoids, the tiny channels where blood exchanges nutrients with liver cells. When nitric oxide production drops, which happens with age and metabolic dysfunction, hepatic blood flow becomes sluggish. Fat accumulates more easily in poorly perfused tissue. Dietary nitrates from beets convert through a two-step process to nitric oxide and restore this circulation. That's the mechanistic basis for why the beetroot RCT showed statistically superior steatosis reduction compared to Mediterranean diet alone. The beets aren't just providing antioxidants, they're restoring hepatic blood flow that the conventional dietary approach never addresses. The fifth mechanism is hepatocyte membrane toxin penetration, and this is where silymarin, the active compound in milk thistle, becomes clinically relevant. Liver cells are constantly exposed to toxins, environmental pollutants, medication metabolites, fructose breakdown products. Silymarin acts at the cell membrane to physically block the binding sites through which many hepatotoxins enter hepatocytes. It also inhibits stellate cell activation, reducing TGF-beta signaling through a pathway independent from caffeine. A systematic review published in Cureus in October 2023, Calderon Martinez and colleagues, analyzed 29 randomized controlled trials covering 3,146 participants across diverse liver conditions. 65.5% of those studies reported significant reductions in liver enzymes with silymarin treatment. The NIH acknowledges the mechanistic evidence. The FDA classifies it as a dietary supplement, meaning no company can invest in getting a liver disease indication approved because the compound cannot be patented. That's the system telling you, by omission, that the economics don't work, not that the biology doesn't. Now, the protocol. Before the specifics, this needs to be stated clearly. What follows is educational information based on peer-reviewed research, not a substitute for working with your physician. If you have diagnosed liver disease, chronic kidney disease stage 3 or higher, active cardiac arrhythmia, active peptic ulcer, or if you are taking anticoagulants, immunosuppressants, or undergoing chemotherapy, Have this conversation with your doctor before making changes. The protocol is designed for adults in the 45 to 65 range looking to protect organs declining silently. It is not a treatment for established disease. The first and highest priority change is switching to filtered drip coffee. 2 to 3 cups per day, black or with unsweetened milk, no sugar. The evidence here is the strongest in this entire discussion. 147,875 people, 33% fibrosis reduction, measurable drops in ALT and AST, documented over weeks of consistent consumption. The type of coffee matters critically. Filtered drip, paper filter pour-over, or automatic drip machine retains the highest chlorogenic acid concentration. Espresso extracts at high pressure and temperature, degrading a substantial fraction of these compounds. Instant coffee is largely devoid of them. French press retains diterpenes called cafestol and caweol that mildly raise LDL. Relevant if cardiovascular risk is elevated. If you have acid reflux, start with 1 cup and assess tolerance. The most common mistake, switching to a specialty espresso because it tastes better. That is not the same biochemical intervention the research studied. Timing matters secondarily, morning and early afternoon. The chlorogenic acid effect on postprandial metabolic spikes is enhanced when coffee precedes a carbohydrate-containing meal. If caffeine sensitivity is a barrier, the decaffeinated evidence is strong enough to justify that substitution. The chlorogenic acid content is comparable. The second intervention is brewed green tea, 3 cups daily of loose-leaf sencha, quality-bagged Japanese green tea, or matcha, not green tea extract capsules, not concentrated GTE supplements. Cases of drug-induced liver injury from high-dose green tea extract supplements are documented in the published literature. Drinking the tea has an entirely different safety profile. The dose in the kidney protection RCT was 7.5 grams of dried leaf per day. Water temperature is critical. Brew at 70 to 80 degrees Celsius, not boiling. Boiling water degrades the catechins significantly. 2 minutes of steeping is sufficient. The interaction to know: catechins bind non-heme iron and reduce its absorption. If you have iron deficiency anemia, drink green tea at least 2 hours after meals. If you take warfarin, the vitamin K in green tea can affect your INR. Monitor with your prescribing physician. If your medications are metabolized through the CYP450 enzyme system, which includes many statins, certain antihypertensives, and several psychiatric drugs, EGCG can mildly affect this pathway. Mention it to your doctor. The third intervention is fresh beetroot juice, 200 milliliters, 3 to 5 times per week. Not canned, not beet powder. Fresh pressed or cold pressed juice retains the nitrates and betalanes the RCT used. Heat processing destroys a significant fraction of both. You can juice at home or purchase fresh cold pressed. Combine with carrot and apple for palatability. Take it morning or mid-morning. The nitrate to nitric oxide conversion peaks 2 to 3 hours after consumption, giving you hepatic benefit through the metabolically active part of the day. Before you start, your urine will turn pink to red after consuming beets. This is called bituria. It affects roughly 10 to 14% of the population and is completely benign. Betalin pigments passing through your kidneys unchanged, not blood, not kidney damage. Tell your family before you start. The real contraindication: a history of calcium oxalate kidney stones. Beets are moderately high in oxalates, and for that specific population, this intervention should be cleared with a nephrologist. The fourth intervention is a daily milk thistle infusion or standardized silymarin supplement. As brewed tea, dosing is lower but cumulative. As a supplement, look for 140 to 420 milligrams of standardized silymarin per day, using phosphatidylcholine enhanced delivery for improved bioavailability. The 29 RCT meta-analysis found the most consistent benefits in NAFLD patients specifically. Silymarin's safety profile across decades of study is excellent. Interactions to know: mild CYP450 effect similar to green tea and potential additive blood sugar lowering in diabetics on medication, worth monitoring with your prescriber. Now, what to ask your doctor. Request a complete hepatic function panel including ALT, AST, and GGT. Optimal ALT for metabolic protection is below 25 in men and below 20 in women. Your lab will mark anything under 40 or 55 as normal, but research consistently shows values above 25 and 20 respectively correlate with measurable hepatic fat accumulation. Laboratory normal and biologically optimal are not the same thresholds. Request a renal panel that includes eGFR plus a spot urine albumin to creatinine ratio. Albumin in the urine is the earliest detectable signal of kidney damage. It appears years before creatinine rises out of range. For anyone with hypertension or diabetes, missing this measurement is a significant gap in preventive care. Add uric acid and ferritin if your doctor is open to it. Both are independently valuable markers of metabolic and liver health that most standard checkups exclude. After 15 years of clinical practice, here's what consistently makes the difference. The people who see the most meaningful improvement implement all 4 beverages together, not just one. Each operates on a different mechanism. The coffee handles the fibrogenesis pathway, the green tea handles the renal oxidative pathway, the beets handle the hepatic circulation pathway, the milk thistle handles the hepatocyte membrane pathway. These are additive effects, not redundant ones. 4 simultaneous mechanisms is a meaningfully different intervention than one. Hydration is the silent prerequisite for all of this to work. Your kidneys cannot filter efficiently in a state of chronic low-grade dehydration, which describes most adults in their 50s. Starting the day with 250 to 300 milliliters of water with the juice of half a lemon before any coffee or tea is not a detox ritual. It's basic renal function support. The vitamin C from the lemon acts as a cofactor for glutathione synthesis, your liver's primary endogenous antioxidant. The error most people make, buying supplements that claim to replicate these effects in capsule form. Green tea extract at high doses has caused liver injury. Concentrated beet powder has a fraction of the bioavailable nitrates of fresh juice. Processed silymarin in cheap formulations has poor bioavailability. The research was done on the whole beverage forms. That is what the evidence supports. What can you expect, based on study timelines rather than marketing claims? Weeks 1 and 2. Improved morning energy and reduced post-meal heaviness. Partially a hydration effect. Partially the early metabolic impact of chlorogenic acids on postprandial glucose spikes. The molecular mechanisms take time to fully engage. Don't expect dramatic changes yet. At the 1-month mark, if you tested ALT and AST before starting, strongly recommended, you may begin to see measurable movement. The Tabriz meta-analysis showed coffee's enzyme-lowering effect developing over consistent consumption. The green tea RCT showed lipid profile changes at 60 days. At 2 to 3 months, this is when structural changes become verifiable. The beetroot RCT showed measurable reduction in liver steatosis, confirmed by ultrasound at the 8 to 12 week mark. If you had a baseline liver ultrasound, this is when a follow-up becomes informative. eGFR that was mildly reduced may show stabilization or modest improvement. At 6 to 12 months, the antifibrotic effect of consistent filtered coffee consumption is cumulative. The renal protective effects of regular EGCG compound over time. The research populations were habitual consumers, not 30-day experiment participants. This is a permanent shift in what you consume daily, which is exactly what the study designs reflect. Stop any of these and seek medical attention if you experience yellowing of the eyes or skin, dark tea-colored urine combined with pale stools, severe upper right abdominal pain, significant swelling of feet or ankles, or blood in your urine clearly distinct from the pink discoloration of bituria. These warrant medical evaluation, not dietary adjustment. Here is where we are. The conventional system gives you a basic metabolic panel, a recommendation to lose weight, and a referral when something becomes bad enough to diagnose. The published research gives you 147,875 subjects, 29 randomized controlled trials, documented molecular mechanisms, a specific evidence-based protocol of 4 beverages attacking liver fibrosis, hepatic steatosis, and renal oxidative damage through complementary pathways. No prescription required. Lower cost than any marketed liver supplement. The gap between those two realities is not a knowledge gap, it's an incentive gap. No one profits from your daily cup of filtered coffee. No revenue model exists for recommending fresh beet juice. The research sits in PubMed, published in peer-reviewed journals, funded by independent academic institutions. None of it makes it into the 10-minute appointment because the system is built around treating disease, not preventing the metabolic decline that creates it. You've spent years going to appointments where you get 10 minutes and a printout. The information covered today comes from journals that are publicly accessible, from studies funded by independent researchers, from mechanisms documented in cell biology. This is not alternative medicine. This is the science that the guidelines don't prioritize because prioritizing it doesn't generate revenue. Get a baseline. ALT, AST, GGT, EGFR, urine albumin to creatinine ratio. Start the protocol. Come back in 90 days with repeat labs and tell me what changed. Leave a comment telling me what your doctor said the last time you brought up liver health. Whether they ran the right tests or moved on without answering. That tells me what this community needs explained next. This is Dr. Harris. See you in the next one.